Hi, this is Larry Bauer, Executive Officer Emeritus of the Family Medicine Education Consortium and Director of the Innovators Network. And I am really excited today to have Dr. Alan Roth and Dr. Luigi Tullo, both from Jamaica Hospital in Queens, talk about a project they've been working on to transform their practice, their system, um, to deliver advanced primary care to a Medicaid, fully insured Medicaid population. So, without ado, I am going to turn things over to Dr. Roth and Dr. Tullo.
Thank you, Larry. So, my name is Alan Roth. I am Chair of Family Medicine and Ambulatory Care for the Medicis Health Network, which comprises Jamaica Hospital Medical Center and Flushing Hospital Medical Center in Queens County, New York. Queens County is known to be one of the most diversified places in the world. Um, and we're going to talk today about our ambulatory care network project. Dr. Tullo.
Yes, hi, I'm Dr. Luigi Tullo. I'm the Vice Chair of Ambulatory Care and the Medical Director of our Division of Population Health for Medicis. This has been an exciting project, which hopefully will help others move towards an advanced primary care model.
So there has been a shift in our network. There's some shift in the nation of a movement from fee to service to value-based care. And the shift works really well in our patient population and in the way we've created our ambulatory care network. So in traditional fee for service, you see a patient in the office, you send a bill, you get a reimbursement. And that's the transaction. And it's very transactional medical care. There's really no incentive to be more proactive in reaching out to your patients and doing things like that. When you switch to value-based care, and in value-based care, we are paid a set amount for the patients that we take care of. One of our biggest insurers is called Health First Insurance. It's one of the biggest managed Medicaid population insurance companies in the nation. And we are globally capitated with them for total risk on about 195,000 patients. Out of that 195,000 patients, about 40,000 are under the direct guidance of our faculty physicians here at Jamaica Hospital, as I mentioned, in a safety net, underserved hospital community. So the mentality is shifting with us. The mentality, because we're globally capitated, and it's not because we're globally capitated, because it's the right thing to do, is to take care of our patients and be proactive in taking care of our patients and doing the right thing by them. Because we're in a mixed system, we can't practice two sets of care. So we give our patients that are fee for service the same value-based approach to care. Next slide. So in the past, as I said, you come in, you get a diagnosis, you do tests. The more you do, the more you earn. A money-driven system to do lots of procedures on patients and do lots of things, but not as much value based on keeping people healthy. Actually, the medical industrial complex that we live in of big pharma and hospital systems and insurance companies and device makers actually makes more money on the more you do. So the sicker the patient, the more you do, the more money you make. And it has nothing to do with health, unfortunately, and quality. So our value-based approach based on our capitated patients is to ensure that our patients are getting the appropriate care that they need, not too much, not too little, what is for them, and keeping them healthy and well and out of the emergency room and out of the ER, and really making patients healthier. Next slide. And, you know, this has been a journey for us. It started about 5 years ago. In our hospital system, the journey towards globally capitated value-based purchasing has been going on for about 25 years. So it didn't evolve yesterday, but our approach to the care has evolved in about the last 5 years, where we looked at different models that were out there. Partially, our project started at the Innovators Network. We've met some colleagues there, Dr. Wayne Jonas, Dr. Scott Connard, who we have partnered with in helping us get some of the data we need and partnering them with us in guidance on what it is to truly be an advanced primary care delivery model. So to succeed in the system, we went from a sick care system to a well care system. We went from being reactive to being proactive. So how did we do this? Next slide. We did it by looking at our patient population and seeing patients where they're at and what their needs are. We didn't sit back anymore and wait. We went out there and we found our patients who were the sickest, or patients who were not the sickest, who haven't been to see us in a long time, so we didn't know if they were sick or not. So we know some of the patients who are this quote super utilizers, horrible word, I don't like it, but it is a term that's utilized. We know who those patients are because they're our biggest spenders, and that's who we're spending lots of money on. And in those patients, we have a care management type of model that works for them. But what we didn't know is those patients that had hypertension and diabetes and obesity and cardiovascular disease who haven't yet had the heart attack, who haven't yet had the stroke, and were kind of under the radar. And many of these patients were not coming in care. They are the ticking time bombs of our patients who are about to have a bad event happen and go and become a high cost patient. Again, I hate saying it in terms of money, but we know that you keep people well, you keeping people well, you're saving money. So you're doing the right thing by the patients. Next slide. So the care we're giving is patient-centered, and from the caregiver's perspective and from all of us, it's better care, it's smarter spending, and we have increased satisfaction of both the patients and the providers. As my partner here, Dr. Tullo, says all the time, some of our doctors feel like they finally got off the hamster wheel because we're doing what is needed to be done to give the appropriate care of the patients. We're giving our doctors the time. We've created something called a high value visit. A high value visit, our doctors get about 40 minutes to do comprehensive care. And during that time, they address not only the physical problems, but the psychosocial problems and the health related social needs. That's what's needed to keep patients well. And addressing these in a 15-minute visit, you barely get through the medical issues, the labs you need to do, and the medications you need to refill. So more comprehensive care and supporting this comprehensive care is kind of the system we created. And we're using health information technology to make it happen and improving ourselves on a daily basis based on the data that we receive on our patients. Next slide. So we, is this yours, Dr. Tullo?
You could do this one. I'll do the next one.
Okay. Sorry about that, Larry.
No problem.
So we use a multi-prong approach. We've created a division of population health under the Department of Ambulatory Care with Dr. Tullo and an administrator, Awali Andakande. And he has helped us create different workflows, monitoring our providers, monitoring our navigators, and we do simple, quick PDSAs to improve the approach to care that we give. We risk stratify our patients. Okay, we want to know who the sickest patients are that are not coming in, and we want to know who the sickest patients are coming in. But the ones that are not coming in, we're reaching out to them. We're using patient navigators. All of our doctors have a patient navigator who is a member from our community that joined our staff. They're not nurses. They're not MAs. We train them on the needs of our doctors. And these navigators go out and work with our patients and with our providers, and they are a bridge to patient care. They will reach out, say, I'm calling for Dr. Tullo on his behalf. We haven't seen you in a year. We see you're on all these medications, and we need you to come in to help get you good medical care and to keep you well and healthy. We created a playbook to address all of the health measures that we need and ensure better workflow to manage our chronic conditions. Next slide.
Okay, so what have we implemented? Well, the first thing we did is for all of our Health First patients, what we did is we developed a risk score because not only did we use what was in our electronic medical record, but the insurer Health First gave us information about the patient's use outside of our network. So we were able to get claims data to develop this risk score and build this risk score, but not only build it, implement it in the patient's chart. So it's visible to anyone that goes into the chart to know if the person is a higher risk patient or not. And this allows us to then outreach those high risk patients, both the ones that are high cost to try to decrease their spending, but also to keep those patients, as Dr. Roth had mentioned, keep those patients who are still, not high cost, low cost, in that area as much as possible. And what we did was we moved away from a clinician-centered to a team-centered approach. And as Dr. Roth stated, the navigators were an integral part of this because, again, patients began creating not only a relationship with their provider through the 40-minute high-value visit, but also with the navigators that were involved in the team that the providers often brought into the room to be able to set up follow-up visits, follow-up testing that needed to be done, but also to introduce that person to the patient so that they could really understand, as Dr. Roth had mentioned, that this is a conduit between the provider and the patient. And then we began doing a proactive outreach. So identifying these high-risk patients, we proactively scheduled them and told them, because of your multiple medical problems, Dr. Roth would like to see you for a 40-minute high-value visit where we're going to create a personal care plan for you to better manage all your problems. We also, when we set up the schedule, created more same-day visits because we know when a patient needs to come in because they're not feeling well, if there's no availability, they'll often go to an urgent care center, and often the management there is not optimal for the patient because they really don't know the patient as well as their PCP. We also began running reports about missing health maintenance care gaps. So patients that needed mammograms, colonoscopies, we were reviewing these so that way that we could reach out to the patients and bring them in. And these reports and apt to assist in what we call hierarchical categorical condition diagnosis to recapture. These are extremely important diagnoses, especially for our Medicare patients, because they are codes that explain how complex that patient is, which, and in the end, also brings in enhanced reimbursement for their care. So this is a look at what the score looks like, and it breaks up into a multiple. What is their total risk score? And the total risk score is divided into 3 risk scores that are added together. There's the absolute risk score, which pretty much is demographics, their diagnoses, medication, social determinants, how the complexity of their care, and it's really the patient about the patient themselves. Then we have the gap risk score, and that really explains to how well the care team is getting the patient all of their healthcare needs that they need, all their cancer screening, making sure their hemoglobin A1C is controlled, making sure their blood pressure is controlled. And then we have our flare score. And this is extremely important because it makes us understand where the patients are getting their care. Are they going to different places, seeing the PCP in one of our ambulatory care centers, but then going to a specialist or going to an urgent center or going to an ER or another hospital for hospitalization? This really causes a disjointed type of management. And we've realized that keeping that flare score low means that the patient is really getting most of their care within our network, which is much easier for the clinician to follow. Again, we also built a special diagnosis column called an HCC category. So when providers are documenting the diagnosis, they look to try to see if there is an appropriate HCC category to choose. So again, to put in a patient who has CKD does not cause a HCC code to drop. But if you put down CKD stage 3 or stage 4, that will create a care gap, a diagnosis to drop. And as you can see, this is pretty much what the providers use when they're placing diagnosis for the encounter. So we initially, under the supervision of the Division of Population Health and under the supervision of ambulatory care, we created a pilot project to prove to leadership the effectiveness of a proactive approach. And this was a medication adherence project. One of the Medicare metrics that Health First and CMS looks at is how well patients are taking their medications. And what was happening is they need to have it 80% of the year. We created a team of 5 navigators to begin to outreach and look at what was happening. When we first started, our scores were very low, and we'll discuss that, what they were before. So what we did is we had these 5 navigators go through a report based on when the patient picked up their last medication refill. And what happened was the report shows an act now. And it tells you that within the next 2 weeks, the patient is going to need to pick up their medication. So these navigators would reach out. We put in an EHR support system and emphasize to all the providers to write for 90-day supply for these medications for hypertension, hyperlipidemia, and diabetes, so that our patients over 65 who may have difficulty getting to the pharmacy will be able to only have to go to the pharmacy 4 times a year. We continued calling patients, making sure, not only patients, but also pharmacists, to make sure that the patients picked up their medication. And at the end of the project, we started out in 2023 with 3 stars for hypertension, 2 stars for hyperlipidemia, and 2 stars for diabetes. After we implemented, we were the only organization within Health First that has about 17 of the largest networks in the New York metropolitan area. We were the only ones to be 5 stars across the board. And this confirmed to leadership in our hospital this approach could really help us in making sure our patients stay healthy, but also that we are able to meet the appropriate metrics.
So Dr. Kulo, can you tell the group approximately how much money did we earn by this project?
This project probably made the hospital about $2.5 million. Just this, because again, each one of these metrics in Medicare are triple starred. So again, we get graded on the number of stars we earn. So we went from 15 stars to 45 stars. So again, it was a big jump up for our organization. And again, for a safety net hospital, $2.5 million is extremely important, because we can then reinvest it into more navigators, more care managers, to be able to begin to even improve more on what we've been doing. So what were some of the results? And these are pretty amazing. So we had these high value visits that Dr. Roth talked about, where providers were given more time to talk to their patients, create that relationship, create that trust, but also being able to try to see where the obstacles of care from the patients. So we did a study based on patients who were high risk, who had a high value visit, versus patients who were high risk and did not have a high value visit. And the improvements were remarkable. So we divide our patients into pretty much 4 quadrants. The right side are the high risk patients. The lower part are the lower cost high risk patients. Those are the patients, as Dr. Roth mentioned, who have all these diseases that are dangerous, but really haven't had the bad outcomes. They haven't ended up in the hospital or the emergency room. The top ones are the ones who are the diabetics who are now on dialysis, or people with cardiovascular, the disease that have had strokes or heart attacks. If the person did not have a high value visit, we spent about $25,460 per member per year. This group, their risk score was 63. The risk score for that upper right-hand corner group was 126, which is pretty much double. So they were high risk, but we were able to capture the really, really high risk patients that are on this right side. And the per member per year spend was $24,345. So we pretty much, with a decrease of about $21,000 just doing that. Now you may look and see at the bottom that the high value visits, the people who had high value visits numbers also dropped in the lower quadrant. And the reason that happened was because we were all capturing those patients before they had the little problems here and there, headaches with, maybe because of high blood pressure and that they went to the emergency room. So we're able to decrease there. This pretty much was reflected in not only in the general high value visit, but also if we look at specific illnesses, CHF, 39, almost $40,000. With the high value visit, it was down to 11,400. Type 2 diabetes, 25,000 for a high risk patient without a high value visit. With a high value visit, it's about $18,000 less. AFib, $30,000 if they did not have a high value visit. Those same another group of patients that got the high value visit, whose risk score still was higher, they had a 10,000. So this obviously shows that by diseases, we're saving money on each one of these patients by doing high value visits. And as Dr. Roth said, saving money in a value-based system is really meaning that you're keeping your patients healthy. But people will say, well, yeah, you're keeping them healthy. Is that really true? Well, Dr. Roth in the next 3 slides are going to show you how true it is.
So the data, cumulatively shows several things. One is we are become very effective in keeping people out of the hospital. And by definition, again, we say it's not just about saving money. Keeping people out of the hospital is an amazing thing for people and their health and wellness and their mental health. So what we've seen during this project in the first 18 months of the project was a 10% reduction in total hospital days. And in the next 24 months, a 21% reduction in hospital days. Next slide. ER utilization. Similar findings over the time period. Almost an 18.5% reduction in the last 24 months of people going to the ER. So what does this mean? It means we're keeping people out of the emergency room. We're keeping people out of the hospital. We're keeping people in our network. We're keeping people healthier. We're making our providers happier. And it's a win-win-win situation for our patients and our institution. Next slide. And this slide is very telling. So excess medical revenue in capitated lingo is the following. So we get a set amount to take care of our patients. We get X number of dollars to take care of the group of patients that we discuss. What we spend, and as I said, we're globally capitated. So if our patient goes to a competitive ER, we pay that hospital ER bill. If they get admitted, we pay that bill. If they go to an outside consultant, we pay that bill. Okay. So by keeping people in network, out of the hospital and out of ERs, we spend less. So going back to the year or so before we started the project, which was about 2019, and COVID, put a big burst our balloon badly during this time, but we still, as you'll see, did well. So prior to COVID, our excess medical revenue, which is what we brought in minus what we spent, what's left? You could either have a surplus or you could have a deficit. So as you could see, we had no deficits. And in the year since we've begun this project, our excess medical revenue went from 42 million to 49 to 62 to 81 to 118 million. 2024, there was a dip in 2024, but the dip in 2024 was not related to our medical care. The dip in 2024 was actually related to the health insurance companies who their star ratings went down. So they were unable to pay us the same amounts per star that we were getting. You might want to explain that a little deeper, Dr. Tullo.
Yeah. So each organization, based on how well each insurance company, the organizations based on them get star rating. How well are you doing is based really on the hospital organization, the medical organizations that are part of that. So again, though our ratings have been going up, as you can see, along with the EMR, some of the other organizations dropped. And what happened was they dropped, they lost the 4-star rating and went down to a 3-star rating. So that decreased the reimbursement that we were getting for each one of our metrics. Having spoken with leadership at the insurance company, they estimated that in 2024, had they not been a 3-star, but were still a 4-star, we probably would have been closer to about 125 to 130 million. So again, always continuing to increase.
Next slide.
Yeah. So what were some of our completed projects? Well, one of the most important projects that we did was put in something called Epic's Healthy Planet, which enables us to incorporate the insurance claims that we get fed directly into Epic and our Medicis EHR information to create a more rational approach to capturing care gaps. So if we just looked at our Epic, there may be a person who we think needs a colonoscopy, but there was a bill dropped last year for a colonoscopy at an outside provider. Well, we don't want to waste time calling these people because they've already gotten it. So the only thing we do is we flag that patient so that the next time they come into the office, one of our navigators is ready with a medical release so that we can get the information and better manage the patient so we know what the result of the test is. So really, it helps us really hone in on the patients that really need certain tests to be done, need certain visits to be done, and we can get them in for that. We currently have 14. We plan to move up to 24 patient navigators who are doing outreach. They're scheduling high-risk patients for high-value visit. They're scheduling patients for care gap. They're calling patients for medication adherence to make sure that they're picking up their medication. We also have navigators who are doing lung cancer screening. So patients who have a history of smoking who would warrant a low-dose CT, we're doing outreach to those patients. And also just generally making sure that any person that's going in and out of the hospital has a quick follow-up with their provider, because we notice that patients who get in to see their PCP really have a better chance of not getting readmitted. And as we all know, readmission within 30 days, especially in a value-based system, creates major issues. So what are we doing in the future? Well, one of the things was, patient providers trying to figure out what are the care gaps needed to be closed, what tests need to be ordered, and everything else. We are, and it's written in process, but we just, as of Monday, went live with what we call a nursing pending orders in pre-charting. The nurses will go into the patient's chart a day or two before. They will, a smart set will pop up telling the nurse that this patient has these care gaps that need to be completed. They will already be checked. They will click a button and it will pen the test so that when the provider goes into the chart, they'll be able to see right away when they open up, these are the tests that should be offered to the patient. The other thing we're doing is we're in the process of hiring social workers to address health-related social needs, which in our neighborhood and where we have our hospitals is extremely important and has a very big impact on patients' medical conditions. We're also working on hiring five care management nurses to follow care plans and help manage the patient between the provider visits. So when the patient comes in, they see the doctor. If, let's just say, insulin was started, there will be orders placed into the chart that the nurses will be able to look at and say, okay, I have to contact this patient every 2 weeks and titrate up the insulin. This will help us facilitate a quicker titration and hopefully a quicker control of our patient, and really avoid that migration from that low-cost, high-risk patient to a high-risk, high-cost patient. And finally, we are implementing a system called Navina AI, which will be rolled out probably by the end of this month. And this is an AI system that completely reads the whole chart, including including things that are in media, not only stuff that's normally be able to be picked up and information that's going to be able to be picked up, but we'll pick up anything, whatever, and offer the providers all the possible HCC codes that are possible with a percentage, of probability that that code is verifiable. Once the provider chooses to put that into the plan, it will pull all the supporting data that's needed. So if it's a diabetic with CKD 3, it'll pull in the last hemoglobin A1C, pull in the last EGFR, will pull in the medications that the patient's on. And the provider just needs to edit whatever they need to for that, but it automatically will then go into the node. So again, all these projects really have been are sort of funding themselves because we're making more money for the hospital, which then the hospital is reimbursing to improve even more the care of our patients. And as Dr. Roth had mentioned, we really are achieving the quintuple of aim of medicine, and we're able to really make patients happy, providers happy, give good quality care at a lower cost, and in where we are, really address the inequities of the healthcare system. Dr. Roth, if you want to mention anything
Yeah,
close.
I think you summarized well. I mean, summary as far as the implementation, and I think the biggest thing was going from a reactive system to a proactive system. And we did that through the use of our navigators. The navigators have been, I think, one of the keys to the success of our program. We did it by risk stratifying patients using data. So I think the combination of those and administration seeing the savings, having administration buy in, that was actually letting us use the money that we were saving to deliver better care. And like Dr. Tullo said, we're really meeting the quintuple aim, and that's what it's all about. So we're very proud of what we've accomplished in this project. Thank you, Larry, for inviting us.
Yes, thank you, Larry.
Thank you for all the work that you've done. As a member of the Converging Health team that has been involved behind the scenes along the way, one of the things that impressed me the most is I remember on the first visit where we came to Jamaica Hospital, the frustration that the docs and the staff had with just how chaotic things were. And I'll just tell this quick story that I heard. One day when people came to work, there were patients lined up outside the door, waiting to try to get in, and it created pressure for the docs and for the staff because they just felt overwhelmed by the demand. And within a relatively short period of time, when you've implemented this model, those long lines were gone. The pressure on the staff was was very different. And I remember some of the docs commenting on how good it felt to be able to take care of patients when the structure is different and it's much more supportive. So, I think that's a really important part um, of your accomplishments.
Yeah, and another example is, at the beginning when we first started testing things, we had a fairly large exodus from our staff. We lost probably about a half a dozen doctors within a 6 month period. And since that, new hiring procedures, new hiring of people that want to buy into this system. We have not lost a provider in years now.
Wow.
So we definitely turn things around from both the patient perspective, the provider perspective. This has been a total win-win-win. Our CEO literally talks about it all the time. At like every department head meeting at the hospital, he essentially is talking about how ambulatory care and this project is really helping to save the hospital. The hospital loses money every single year by a lot, millions, multi-millions. And this excess medical revenue that we're generating in upwards of $100 million is what's keeping the hospital afloat at this point.
Yeah, and a backstory, Larry, on what you mentioned. Uh, After we had implemented this, myself and at the time the assistant vice president went to the center that we were piloting, and we walked in. Now, we'd always walked in and it was chaos. We walked in, there was nobody in the waiting room. I literally ran back and read numbers because I thought, oh my God, what the heck? We just broke the system. And when we looked, and I presented it to Dr. Roth and the vice president, I'm like, guys, I don't know what's happening, but we're seeing just as many patients, if not more, on certain days than we did when we had the chaos. And it's because now it's organized. Instead of having everyone come in because they feel like, they got to get the donut before anyone else, they know that there's going to be a slot later in the day for them, and they come in then, and it decompresses the staff because now they don't have to worry about fighting with patients that say, I've been here for 2 hours. We just tell them, come back at 1 o'clock and the doctor will be very happy to see you. We make sure that they call the centers before. That way there we can tell them what time that same day slot is open, and it literally decompresses and it changed the feeling in the clinic even when you walk in. You don't have to talk to anybody. You could just feel like everyone was relaxed. So it was a real big victory because again, I was very worried that we had broken the system putting this in.
Right. So I have one other question for the two of you. The converging health whole person risk score that is at the core of the IT, the data analytics. How has the implementation of that, how has that changed your practice of medicine?
Well, I mean, as Dr. Tullo discussed, those patients who are high risk and low cost, you know, we didn't pay attention to those patients. We didn't know about them. We weren't able to find them. We had no idea who they were. But when the marriage of data, of the clinical data along with the financial data came together, we were able to see how many of these, I hate to use the word ticking time bombs, but we had a lot of them, and most of them haven't been there in a year and sometimes more. You might say those were the patients that, we should be taking, we are saying those are the patients you should take the most care of, but we were spending the most time taking care of well people and doing physicals on well people and seeing coughs and colds. And the people who were truly the sickest, we were not seeing. And this being able to be proactive, to go out and know, like, this clinic has 400 of these patients assigned to them. We got to go out and get these patients in. And that hence was the creation of the high value visits and the same day appointments. Like, we totally restructured everything we did. And we couldn't have done that without knowing, who these folks were.
Yeah, I think, one of the things, we had so many patients who came in who said that they were fine. First visit, I'm okay, everything's fine. Take your blood pressure, 180 over 100. You do their cholesterol, their bad cholesterol's through the roof. So they automatically slid into that low cost but high risk category. And again, you could see the score just jump up from one visit to another. The other issue is we all, not only did we take care of those patients that Dr. Roth truly said are flying under the radar, but are a ticking time bomb, but we also realized that giving the better care to those patients who are high risk, high cost, some of them moved down from the high risk, high cost in time to a high risk, low cost because now they weren't going into the hospital 2 times a month because their blood pressure was controlled, their diabetes was controlled. We were controlling their CHF and they weren't coming in exacerbation. They started eating better. We got them on a better regimen of medication. So it not only helped avoid the people from the that lower quadrant, that low risk, high cost patient from moving up, we're also able to move some of those high cost, high risk patients down where their expenses now were. And if you could just imagine, $25,000 or $30,000 for AFib. And if you get them controlled and now they go down to $1,000, that's pretty much their medication and, a couple of visits in labs. So that's a big impact on the system and a big impact on our patients' lives.
That's really fantastic. The thing that really strikes me is that the cost issue is a surrogate for suffering. When people are associated with high costs, that means bad things are happening. That means they don't get to work. That means they can't take care of their family. They can't have the life that they're capable of. And I have to tell you, from my point of view, as one of the consultants who's been working with your team, it is so heartwarming to feel the impact, the difference that's being made in all of the lives. It'd be just fantastic to be able for the patients to be able to tell their stories about the impact of this project and helping them to have a better life. So I just have to, you guys have done a fabulous job. You stuck with it. You championed the methods, the advanced primary care model, and I think you're a model for the nation.
Thank you, Larry.
Thank you.
So I'm going to bring things to closure. Thank the two of you for all the work. Thank your team for all the work that is going into this. And I look forward to watching the progress that happens in the coming year.
All the best.
Yes. Everything. And I thank you on behalf of all our staff, because if not, it would have just been an idea in mine and Dr. Roth's head. They really were the people that took the idea and ran with it. And they're the major part of the success, because without them, this would never have succeeded.
Very cool.